Good morning, everyone. This is Julie Shills with the Patient-Centered Primary Care Collaborative. Thank you so much for joining us today in our continuing series on care coordination. We are thrilled with our presentation today, and in looking at those of you who have joined us, I see a lot of familiar faces, friends of Patient-Centered Primary Care, and those of you who are working tirelessly to promote patient-centered care in your communities. Today, what we're hoping for, if you have questions during the presentation, please feel free to put those into the chat box, and I will be looking at those questions and organizing those for our question and answer period. The other thing I want to let everyone know is that we will provide the PowerPoint and the recorded session of the presentation on the Patient-Centered Primary Care website. That website is www.pcc.net. On behalf of my fellow co-chairs with the Center for Multi-Stakeholder Demonstrations and the Care Coordination Task Force, Sherry Erickson, Guy Mansudo, Nandan, Anshu Chowdhury, and Jennifer Lord would like to welcome you to today's presentation. We are thrilled today to have Dr. Holly Cleaney. Dr. Cleaney is a practicing physician with Latham Medical Group in New York. She is currently the working group leader in the Capital District Physician Health Plan's Patient-Centered Medical Home Project. She's doing amazing work within her practice, bringing together the work of care coordination within their practice and bringing that together with their hospital systems as well as other specialty partners. So with that, I'd like to turn over our presentation to Dr. Cleaney.
Thank you. So, as my title slide says, this is expanding the team into the healthcare community, one practice's experience from the ground up. So, I'm attempting to advance my slide, and it's not advancing. What do we think?
Holly, why don't you go ahead and try again and see if it's just taking a little bit of time.
I pushed it a few times.
Yeah, did you try clicking?
Okay, it's working. Okay, so objectives for the talk. Develop a strategy for coordinating care effectively for patients across hospital stays and through specialty care experience is in areas without shared electronic records. And I definitely need to put that out there. You know, I've given the talk to people who already have their practices and their specialists and their hospitals all on the same electronic record that can see all the information across the board. And so if that's your situation, this is definitely less of a talk for you, because in our area, it's a big part of coordinating what we do is trying to get the information we need. So that's our experience. And also going on to recognize the role and create systems to incorporate the office team into these care coordination efforts. So background information, again, I'm Holly Cleaney. Latham Medical Group is my practice, which is an 11 provider, all family practice, private practice. And we are one of the business units that is part of Community Care Physicians, which is a multi-specialty group. And Community Care basically helps us do our billing and advertising, but we essentially run as our own business unit and make our own decisions, et cetera. The specialists that are in our system are on the same electronic medical record, but we don't have any specific hospital affiliation, and that's really the only way that we share electronic records is within community care. So my medical home experience comes from CDPHP's Patient-Centered Medical Care Pilot Project. CDPHP is a health plan, and the health plan actually sponsored this project for us. They recruited 3 primary care practices in the area for phase 1 of the pilot program, which was 2 years. We just finished up those 2 years in January and now entering our 1-year extension. And there were a lot of the goals of the program, but one of the key features that was measured was paying us differently. So a severity risk adjusted capitation model, if you want to call it that. Basically, the patients are given a weighted score on how sick they are based on actuarial data, and we are given a care management fee depending on how sick they are. In addition to that, we are given bonuses based on our efficiency and our quality scores. So our quality scores are how we do on our HEDIS measures for this population, and our efficiency scores are based on our utilization of hospitals, radiology, pharmacy, ER, and specialty care in terms of how much that costs them. So, the idea going into this for the plan was that if, there's other lofty aspirations that they had, like saving primary care in general, but the premise was if they can pay us more, free us up to do what we need to do and not be tied to fee-for-service billing only, we could provide better quality care for the patients and actually more efficient care, so in the end save them enough money to support the project. And with the data we have so far, at least for the first year, the second year is still coming, it was clearly right on in terms of exactly what they assessed. So it was interesting. So that's the background of where we are. Basically, we finished the 2 years, and now the program is actually being expanded into the community. So there's 20 plus more practices actually in phase 2 of the project within the community. And so we're moving forward. It's very exciting. So before we go on to what I'm going to talk about, we thought we might do a bit of a poll to just assess the audience that we have. So we're going to, I'm trying to do the poll, but I'm selecting the wrong one. Here we go. Share with us any care coordination initiatives that you are currently working on.
So if all of you would select any of these that apply within your organization, you might be a practice, you might be a healthcare delivery system, you might be a health plan, you might be part of the Care Continuum Alliance, any way that you might be impacting care coordination, we'd love to hear from you.
So we have about 71% that have voted. Give you another few seconds.
And those of you who are voting, if you're inclined to just briefly within the chat box share with everyone some of the work that you're doing, that would be helpful as well, along with any questions that you have for Holly at the end of her session. Holly, I'd go ahead and we have a pretty good number who have voted. This is incredible. I think we can go ahead and close the poll.
Okay. And then I can share the poll numbers. So we have, it looks like about half doing these types of things, which is good, which is great. So some of the people will be starting from ground zero. Some people can have things to share with me and everyone. Okay, so the patient-centered medical care model. In our practice, TransferMed was contracted by CDPHP, and we had them helping us at the highest level in our transformation. So if anybody hasn't seen this slide, it's part of TransferMed's website. This is just the scope of what we tried to work on, and then obviously this talk is focused on the care coordination aspect of it. So I just kind of went through some items to consider, and if you think about these items to consider, they're items to consider for every piece of the puzzle that you're trying to accomplish when you're trying to make a transformation into a patient-centered medical home. Process mapping, taking a clinical perspective on your patient's experience, whether it's within your office or when they go to the specialist or when they enter or leave a hospital. Trying to understand what your referral patterns are, especially in the care coordination aspect of it. Patient education is always an item to consider, taking the time to inform the patient on this specific item, getting them involved in the importance of communicating with you and with their specialist appropriately, so they know what to expect when they go to the specialist and they know what to expect of the specialist. What is the question we're asking? Do we want them to assume care of this problem, or do we want them to just answer our question and then you don't need to see them again after that? So if you educate the patient and empower them, it always, everything goes way better on almost every aspect of what you deal with. Staff education for sure, setting the tone on the importance of staff involvement with care coordination. When it's been 2 years, and finally the other day I heard one of the staff members, one of the nurses, starting to question a provider when that provider went to refer a patient to a specialist for a particular problem, because she's seen other providers in the practice just work up that problem and manage it within our practice. And to have that, we've set that tone well enough that the nurses can pick that up and be part of the whole team, understanding that we want to try to do as much as we can for the patients ourselves was I felt a very wonderful thing that we've done. And it's clearly not across the board, but that I thought was great. So care coordinator, we have one of those, having a point person to assemble data and experiences, having a team approach, dividing the roles of your team members clearly on all aspects of what you work with. Communication, of course, key to establish structures of communication that are appropriate to both celebrate successes and identify areas of improvement and follow up on the things that you do. So in the scope of care coordination, we decided, and it's been recommended, to focus additional attention on, the small successes, the low-hanging fruit, the things that, you can first and most appropriately deal with. So hospital care specialists and urgent care and emergency departments are probably the best places to start when it comes to working on this piece of the puzzle. I won't go through this whole slide. So again, just to go through, this is kind of a wish list in care coordination. How would we like it optimally? Is it going to get to optimum soon? Probably not. But clearly, you want to try to establish a patient-centered system. Communication, again, is ideally, it would be wonderful we all communicated via patient portals and electronic systems, but of course most of what happens these days is via faxing. Timeliness, you want to have very timely communication. You want to have accountability where you hold each player accountable for the patient's experience. Cost-effective care, of course. Encouraging the specialist is the big thing, to respect ancillary care, testing procedures, not repeat things you've already done or perform unnecessary testing. And then, again, other elements to consider not only in care coordination, but all of the aspects that you work on is prepare for today's visit, review the patient's last visit and test results, identify opportunities or breakdowns in the system regarding clinical information, and after the visit, ideally giving that patient a summary of, what you accomplished that day and what are the next plans. So what we've done within our project is 2 of the practices in the pilot project met several times to tackle coordination with specialists. Initially, we considered who we utilize most, who our biggest problem practices or providers were. Those practices that order tests even when it's not necessary just because they own the scanner, or that always prescribe the most expensive medicines or don't communicate with you well. Those are certainly people you want to target. However, is it better when you're starting out this type of thing? And that's what we decided, to maybe go with those practices that might respond most favorably to having a meeting to deal with these issues. And so we talked about who we knew personally and who we might meet with in that regard. And then, of course, establishing what we're asking of them when we're having a meeting with the specialist to coordinate care across our practices. So this is just a list of what you might want to consider. I believe this is something I don't need to go through. It's something that, I think it came from the TransferMed website. It's just a tool in terms of all the things you want to think about in terms of timeliness. What are you expecting from a practice when you send a patient there, and then what can they expect from you? So when we met with the specialist, some of the things that we wanted to make sure we talked about were what are the benefits of working with us and how can we be beneficial to you. Clearly, the ultimate goal, hopefully, for both practices is improve patient care and patient satisfaction. And one of the things that's recommended, and if you want a practice to work with you and do all the right things and get your patients in appropriately and communicate with you well and provide cost-effective care, what's in it for them? Well, clearly, better established referral patterns and communication is something that you can hope to promise them. But another thing has been suggested that you offer to coordinate all of their refills. How much would a specialty group love to hear that all that paperwork and phone calls and things for the patient just to renew their yearly PPI is going to be, coordinated by your practice? Certainly it's more patient-centered, it's more within the primary practice, and it cuts down on their work and it allows you to be more involved in what's going on with the patient. So these are the things that if you're going to decide to meet with specialists like we did, you can talk about and encourage. So when we had our specialty meetings, who attended? Our care coordinator and or our office manager to kind of work on follow-up mechanisms and tweak processes already established at the first meetings, and the physicians to lead the discussions. And so we had a well-defined agenda at these meetings. We discussed each other's roles in communication. We asked them what they want us to send to them and what communication we want back. And we tried to establish better avenues for efficient emergency contacts, and we found that it was very forthcoming that the practices wanted to give us inside lines and how to be very timely to be able to get patients in or get information from them. And we definitely brought up the whole aspect of cost-effective care and asked them, are they working on evidence-based guidelines in terms of how often they order tests? And are they trying to utilize generic prescriptions when possible to limit the cost to the patient and to the system? And the other idea of, if you're sending a patient, is it a consult and return to primary care versus a consult and assume treatment, so that they're not continuing to go every year just because when it's not really necessary, and we can resume the management of that particular condition. And we found that most of the time it was relatively well received, these conversations that we had. So again, we collaborated with another practice to do this. We had every other month meetings. We kind of divided and conquered to meet with different groups, and then we still have to follow up, formulate plans and mechanisms. We kind of put a little bit of our work with this on hold because now, as we go into the second phase of the project, it's not just going to be two groups that are kind of working on making our needs known. It's going to be a lot bigger group that can go and meet with a specialist and maybe get a lot more accomplished. So that's just getting our feet wet in terms of the coordination with specialists and what we've experienced so far. What we've done, this is one more slide I just thought that was timely when I was making my slides back at the beginning of in the fall. So that this is out there, who's taking care of the patient, and rather than making it a turf battle, if we're on the forefront of making it a coordinated effort and in a positive way, then hopefully we'll be ahead of the game. So hospital coordination is what we did a little bit more with. We worked on that. In our initial planning stages, we kind of, here's some considerations. We tried to define our patients' most utilized hospitals in the area, and we tried to decide what information we wanted from the hospital and how to most efficiently get it. We had a lot of conversations about, well, what pieces of information are important to give to each hospital to make sure they send us. And what we ended up finding out is that rather than making this huge long list of what they need to send to us, they need to send us anything as long as it's immediate. And then we can take it from there, because with our internal processes, we have way more control of that. So as long as they get us the information or the idea that the patient was in the hospital, in the emergency room, we can take it from there and get what we need. So that's really all we went to the hospitals with, is how quickly can you get us information and in what form that the patient was there and we need to follow up with them. So the contact person we sent was our care coordinator. to reach out to the hospitals. And then, even more importantly, we tried to define within the practice what we will do with the information once we get it. That's way more efficient than what we had been doing. You know, before we really took on this initiative, it was very ad hoc. When you get a patient back from the hospital, half the time it's 2 weeks later and they've already been readmitted. You have a very random amount of information in terms of the hospital discharge and records that you needed, and the patient half the time didn't have their medication list, and it was a very inefficient, unsuccessful visit. Now we're way on top of it. We're very prepared when we have these visits, and we're reaching out way before, you know, immediately after they get out of the hospital. We tried to define, again, who on the team takes what role in that process, and I'll give you how we did it very much in detail. So again, this is another TransferMed website source in terms of if you're embarking on these types of things, what are the things to think about that you want to talk to the hospitals about when you go to visit them. And so what I went through, I just thought it was an interesting exercise to see the variability of, you know, who met with us, who's working on these types of things. Across the board, it's variable. The good news is that a lot of the hospitals are working on these types of initiatives, and we're all on the same page. We all want to reduce hospital readmissions. We all want to ease the transition of the patient from the hospital to back to home and to primary care. And I just figured I'd show you all the things that were going on in our area, and the variability, like I said, of all the different hospitals that we're dealing with. So Rose went out, and so the rest of the slides basically tell you who met with her, and then what was the mechanism established for notification of the admission or discharge to us, and then how we could obtain the records once that happened. So the first facility that we met with was Albany Medical Center. They're clearly the hugest referral center in the area, and it was the Assistant Director of Case Management and Social Work that met with Rose. And they probably have the best system, because what happens there is anytime a patient is registered, either to be admitted to the hospital or in the emergency room, the minute that tech goes out, talks to the patient, puts all the information in and closes down that screen, an automated fax is sent to the primary care office. All you get is a face sheet with the patient's information and the doctor of record that's admitting or treating. But that's okay. It's something. It's immediate. It's a well-defined process, and it can't be messed up. So the other thing that with Albany Medical Center is that there were some other meetings, and there have been ongoing meetings with some of the other physicians and higher-level managers, both from our organization, Community Care, the multi-specialty group, and from Albany Med to iron out some other means of communication. Also, they're trying to automate a face sheet on discharge, not just admission, and also even more beneficial would be that we get read-only access to their EMR system back and forth, so they can see our EMRs when the patients are in the emergency room and they haven't been notified that they were coming or have any information on them, and vice versa. If we don't get the information by the time the patient comes back for hospital follow-up, we can go right into their record. It hasn't happened yet, but we're hoping. So St. Peter's Hospital is another larger hospital in the area. We have a unique situation with them in that our patients are admitted to the family practice residency program there. So the way we're notified about their discharges is actually when one of the residents goes directly into our electronic medical record system, which we share, and sends a message directly to the provider to say a quick little blurb about what they were admitted for and what follow-up needs to happen. And that is the trigger for our in-office system in terms of the follow-up. Seton Health is another group of smaller community hospitals. The Assistant Vice President of Business Development and the Medical Director of the hospitalist group met with us. And for that, most of the time, the only way we know the patient's admitted, because the records trickle down, is that either the patient or sometimes the hospital calls and makes an appointment for the patient. Northeast Health is another group of 2 community hospitals that we work closely with. The clinical resource manager and the clinical care coordinator and the discharge planner met with us. In their case, we used to admit to one of these hospitals, and so before we left, we tried to establish a system with the hospitals that we were turning over our patients to, to carry on what we used to do. When we were admitting and discharging, we immediately after discharge would call our office and leave a little stat dictation with a brief summary of what happened and what the follow-up was that would automatically be transcribed into the EMR, and the record would be available immediately. So the hospitals do that sometimes still. If they don't, then the way we know is that this hospital, this group of hospitals also has some grant-funded programs, and so they've made an initiative that they are the ones that are calling for the hospital follow-up for the patient. They're not leaving that up to the patient. And that simple intervention they're studying right now to see whether that reduces readmissions and allows the patient to actually get in and see the primary care in a more timely manner. In their case, we have 24-hour access to their health records, so we can more easily find the information in a timely manner. So some other initiatives that are going on in the area I just figured I'd go through. The COACH program for transitional care is a grant-funded attempt at reductions in readmissions 30% for 30% in a year. And it involves both the health plan that we're working with and this hospital, where all of the patients of the one health plan, as well as CHF patients regardless of payer, and they're going to be adding more disease management programs later on, those are the target, that's the target population. And what happens is the hospital staff makes those follow-up appointments, but the hospital staff also does in-home visits to the patient until the transition to outpatient care is deemed well established. So when they go in, they clearly focus on medication reconciliation, red flag identification, primary care and specialty follow-up to ensure that's in place, and promoting the patient to be well empowered with their own personal health record and their patient medication list. So another few of the hospitals that are in the area, the Ellis system is some community hospitals. Those other titles, as you can see, we got lots of different titles that we met with. They basically, the patient or the hospital may call if we're lucky to get an appointment from them, and we call and get the records and then set our process in motion. Currently, we're trying to work to get access to their electronic record system. Saratoga Hospital is another place where the director of discharge planning met with us, and the way we are informed they are discharges that the patient calls for a follow-up appointment or the hospital if possible. The last one is a Veterans Administration hospital. Luckily, rarely our patients are there, because the only way we're going to be able to get any records from them is when they show up in our office. Often they actually have to sign a release to say we need to send that at that point to get their medical records. So clearly that's the least timely and least efficient means of care coordination. But that's something to be working on. So some of the initiatives that are going on here is that the plan that we work with, CDPHP, has embedded a case manager in our office 2 days a week, partially for the hospital coordination piece, but also just to do case management in a more face-to-face way with our own patients. And so she actually sends us a weekly listing of admissions and discharges for all those people that fell through the cracks from the other mechanisms we've set up. And then we also send her the results of our admission tracking tool, which I'll tell you about a little bit later, with diagnoses for her to cross-reference. This is just another program that's going on in terms of all the initiatives that are going on in this arena. The plan also has a pilot program that was adopted, and it's focusing on CHF, COPD, and coronary artery disease patients identified by the plan while they're inpatient. And what they're doing is having a nurse see them within the hospital, and again, 24 to 48 hours after discharge at their home, share the information for what they found out with the primary care physician, and ensure all of the things we've talked about before in terms of coordination of care. And it's not as pertinent to us because we're paid different already, but the idea is that the plan is trying to support the post-hospital visit as being a very necessary and well-paid-for visit, and they're encouraging the providers to bill a 99215 for that visit if they can appropriately document and spend the time. So they also have in that program a nurse placing a follow-up visit 7 to 10 days after the visit with the primary care provider to ensure all needs were met. So those are some of the outside initiatives that are going on. What we've done within our practice, I think, is one of the ways that I've seen a huge transformation. We created a process so that we act immediately on any information regarding an admission or discharge in a coordinated manner with well-defined team roles for each member in the office, both for emergency room visits and hospital admissions. So, you know, in the past, something would come in via fax that a patient was admitted. It would just get sent to the provider in their mail. It might be looked at in a day or two, you know, and it was very ad hoc. Now, the medical records people, anybody that's sorting things off the fax machine knows to immediately grab that, act on it, pull it out, and start the process in motion. So just quick details about our hospital discharge follow-up process. The way we're working it is that anything received indicating a patient was admitted or in the ER via mail, fax, that's in paper form, is when it's received in the office, it immediately goes to medical records and to the nurse coordinators. Medical records obtains as many records as are available on the list of things we want to state. And we have 2 designated floor nurses who volunteered to take on this responsibility to be the hospital coordinators. We divided up the hospitals, and they immediately contact the patient as soon as we find out to ensure that we have an appropriate time frame appointment made for follow-up. They review the medication list and any questions regarding it and really try to reconcile it and pick up duplicate ACE inhibitors and beta blockers, pick up diuretics without potassium, things that are the classic immediate bounce back things, and try to do that in a way more proactive manner than waiting until the patient shows up in the office. And just in general assessing the patient's status and picking up whether they're doing okay or they're crashing and burning. And on the other end of the spectrum, if the first indication that a patient was admitted or discharged is that the patient calls for a follow-up appointment, we have the receptionists, you know, very well trained that it's their responsibility to complete a template where we get their facility name, the patient date of birth, date of discharge, and appointment is made on that call. Immediately the information goes to our nurse coordinators and medical records so the rest of the process can be followed, and should the nurse deem that the appointment that was made was not an appropriate time frame, she can always change it at the time. A note after the nurse contacts the patient, she creates a note in the system, sends it to the provider, so the provider can be aware of what's going on and review the records. So, you know, if there's any other things that we're going to need by the time of the appointment, like cultures that are still pending, et cetera, we can send that back to medical records and be well prepared by the time the patient comes in for the hospital visit. And obviously part of the whole protocol is that whenever possible, the hospital follow-up visits are scheduled with a primary care provider, even if we have to be reasonable at changing our schedules around, whereas before we didn't stress that as much as possible. So what we also incorporate in our process is a tracking tool. It's an Excel spreadsheet that all the offices have access to. It's managed by our care coordinator and the nurse coordinators, and it has all of the fields that I listed. So there's a lot of things to enter. However, if it's done well, it can really give us a lot of information on things that we want to know about. Frequent flyers in the emergency room that case management may be indicated for. Readmissions. So every readmission is a problem. We need to dissect our process and find out whether we could have prevented it anyway. We get better stats on our hospital utilization, who's communicating with us in a timely manner, what patients are going to the emergency room without our advice, because we have a field in there for whether they were advised to go or whether they just went. And then the common diagnoses being admitted. So what benefits have we seen? Well, just the patients getting that phone call immediately after they were discharged is a huge thing to them. And especially since we don't admit any longer, we really feel that that's added back in a great dimension for at least feeling like we have some place in their hospital care. The provider and the patient are definitely feeling way better prepared at that post-hospital visit, and it's much more productive, and we hope that eventually what we're doing is reducing readmission rates with all these efforts. So yet to accomplish in our efforts are meetings with urgent cares and emergency rooms. There are many specialist groups that we have to yet meet with and further define our needs with them. Follow-up on the initial meetings we've made definitely needs to happen, and just continued improving the time frame and consistency that hospitals notify us of patients' admission. We're hoping that that will go even better now that we have a huge force in our project rather than just 2 practices working on this. So from here, certainly, where do we go? Continue the improvement and integration process with other elements of the patient-centered medical care model. Identify new sources of funding to continue with our efforts. And certainly implementing and expanding the things we're already working on with our patient portal, virtual visits, etc. And so that's the end of my talk. Any questions would be about anything that we may or may not be working on are very welcomed.
Thank you so much, Holly. Based on the number of questions we're getting in the chat room and the number of people who are participating, there are quite a few questions, and I'm just going to need to tell the audience we won't be able to get to all of them. But they're questions ranging from how does meaningful use accountable care organizations fit within patient-centered medical home to there's some operations people out here who I have a strong affinity for asking some very detailed questions. But I'm wondering, before we get into these questions, as this work is about being patient-centered and working with our patients and families, perhaps you can share a story about how these efforts have actually had a positive impact on one or more of your patients.
I think in general, especially with the hospital follow-up system that we created, I think, I can't think of one specific instance, but I think just that outreach call is very huge. The nurses all say that, it's surprising to them that they just got home, they don't know what they're doing, they're in a daze, and then they get a call from, their doctor's nurse. And it's just one of those things where they feel like, oh wow, they know what's going on with me. They care, they're reaching out to me already, and they're helping me, figure out what I'm doing here at this point in time after I just went through that crazy situation. So I think that probably that's been the best, aspect of the patient-centered part of it. And then, just working on that patient empowerment and the idea that, well, it's not just you're supposed to know what's going on with me. It's I should know too. I should bring my medication list. I should, have an idea of who saw me in the hospital and what happened and things like that. So I definitely think it's those outreach calls that the patients feel way more cared for and acknowledged that I find is one of the best things.
Thank you. There's a few questions that sort of surface around training and roles, and I think I'll start with one of the broader questions of how have the roles changed within your practice now that you are coordinating with the hospital system and other specialists? So whether it be your clinical staff or your non-clinical staff, perhaps pick one of those roles and how it might have been for them before and how they've changed their role because they're helping to support these endeavors.
Yeah, I think medical records is a key piece. In the past it was just pick off, sort everything that comes through by provider and not pay attention to what it is. And now they're definitely empowered to understand, what's the form that needs to be acted on in a timely manner. Anything that seems like it has anything to do with a patient being in the hospital, they know that it's their high priority and they're very much counted on to be the initiator and the spark to say, okay, this patient needs attention and I need to get this to the right people and I need to find all the information about it and seek the records out. And so medical records is much more empowered and understanding of the things that we need. The nurses themselves that are reaching out, they're getting to use their clinical knowledge and they're getting to coordinate the care of these patients and be on top of what's going on and understand again that this is a huge thing that for patients. The receptionists, in and of themselves, it used to be they just get a call. Okay, you were told to follow up in a week. Okay, let's see what we have in a week. And now it's no, we need to get you in with your provider. We need to make sure we're answering all these questions that we need to know about, and I need to make sure this information gets moved on in a timely manner. So I think everybody's just more empowered to know that these specific instances, there's very important things that need to be done. So they all feel like they have their role in doing that great care coordination piece for the patient.
Thank you. I think some of the other questions, we have a few questions. Carrie and Beverly are asking very specific questions. If you could share any of the templates or tools that you use in the process. One of them is the template for post-ER hospital follow-up and any Excel spreadsheets. Would that be a possibility that we can put on our website to have available for folks as they're moving forward in their journey?
Yeah, interestingly, that's one of the things I'm about ready to work on is we don't have a complete 100% template for that post-hospital visit to be used from front to back. So that's something I'm in the process of working on through our system. But at least, the quick template that we have for what the receptionist needs to ask the patient. We definitely have the template for what the nurse needs to cover with the patient when she calls them. And then really the Excel spreadsheet is basically, it's already on there in that one slide. Every single field on the Excel spreadsheet is right there that we have. So it's just a matter of creating it with all those different fields that you could know how to search. So I could certainly share, and Julie can tell me how to, the two templates that we have for the receptionists and the nurses. Does that answer the question?
Oh, I'm
Hello?
sorry. I had put myself on mute. I wanted to let everybody know, thank you for that, and we can get that up on the PCPCC website. The other thing is I had shared a link that was sent to me in the questions, and it seems like it might be expired. We will find that article, and we'll get that up on the PCPCC website. Some of the other questions are just some of those basic questions that I know many of us who are working in communities is we live in a world that patients don't necessarily pick their primary care or identify it, or there's not a link within their insurance plan to link back to the primary care physician. One question in the chat box was, how do the hospitals really identify that the patients are yours?
Yeah, that's a good question. I think most of them, it's by patient report. Who is your primary care doctor? Probably that I would assume, but I don't know for sure, that they have to ask it every time they register the patient. And as long as they keep those registries of our appropriate information on board, so when they do send us information, it goes to the right place. But I believe that it's more based on patient report. So if the patient doesn't have a good idea who their primary care provider is, then the system's not going to work well. But if you're doing good primary care, they should know who you are. That's part of our job, is to make sure they understand that we're reaching out to them enough that they understand that we're their primary care provider.
We have, thank you for that. There's a couple questions related to training and potentially, what is the training for any care coordinators that you have in your system? And there's also another very specific question, and I think it's related to the transitional care coaches around training that was necessary for folks to be successful in their roles.
Got it. Most of the initiatives that I went through are actually not within our practice. They're kind of some of the external things that we just are lucky enough to be able to work with. So I can't speak to who they have and who they trained. I'm assuming they're care coordinator type people or case manager type people that they put in that role from the hospital plans, or from discharge planner type people from the hospitals. But I can't answer that question because those are more external sources. When it comes to our care coordinator, we hired a person and we kind of said, well, tell us what you want to do. These are kind of the things that we want to do, and her role is certainly a work in progress. I think of the care coordinators that I've met in people doing this, everyone has a different idea of what's important for their practice, because some of them feel that their nurses are very strong in a certain aspect and they don't need extra help. Other ones feel like the nurses need help in certain areas. So in our case, the care coordinator works a lot on this hospital piece, and helps us run reports and do our registries and reach out to our patients and identify the ones that need care and help us work on achieving our HEDIS measures more by running reports through our EMR and understanding who our patients are that aren't coming in. So hopefully that answered the question. I can't speak to all of it.
That's incredibly helpful. I think one last question about some of the details of your program, and then maybe we'll move into meaningful use and accountable care organizations because we're reaching the top of the hour. But there are quite a few questions wondering if you're considering how you might coordinate or collaborate with pharmacists.
Yeah, actually, we are very excited to have a program that's going to be set up within our office. Right now, there's an Albany College of Pharmacy who has had a role in the family practice residency in the area, where they actually have an embedded pharmacist that is at the site almost all the time during normal patient care hours, and then the trainees, you know, the PharmDs that are in the process of their education go there and they learn and they deal directly with patient care. So that's been in progress for a long time, and we're actually going to be one of the second sites that I think that they come to. So that's where we're working on coordination with just having a pharmacist within our office. When it comes to reaching out to other pharmacists, that's not even something that we've come to, you know, that part of the list yet. But it really would be great. So I think in terms of having an embedded pharmacist in the hospital, that's going to be, or in our office, that's going to be wonderful. But certainly, yeah, reaching out to the pharmacists in the community is another something that we're going to have to deal with in some way. Any ideas? Let me know.
There was a question. Yeah, so there's a call out to all of you. If you can share any of your experiences and how you're working with pharmacy. I know a couple of you, we had in one of our previous care coordination calls, HRSA on the line talking about their patient safety collaborative, bringing pharmacists and primary care together in a learning collaborative to work towards care coordination. One question from the group really talked about your patient-centered medical home journey and a little bit of when, you know, how long did it take you in the process to be kind of ready for the pilot was essentially the question that came through in the chat box.
Okay. Yeah, we actually, for probably about 6 months prior, maybe 8 months, we started, you know, we went to an IHI conference, and some of the people in the practice did, and we started learning about it. And even before the actual pilot started in January, TransferMed was engaged, and we started working on the culture. That was clearly the key piece of where you need to go with this. You need to make sure that everybody's on board and that, you know, you understand who you're working with. I think that if nothing else, of all the things that we've done, going through the personality questionnaires that we did and clearing up some of the long-standing issues that we had in the practice with, you know, disagreements about this, where we just dig our heels in and not be willing to change, that needed to change before we even were ready to focus on some of the details of all this stuff. So the culture piece is huge, and if you don't work on that in the beginning, I think that you're just going to continue to spin your wheels. If you get, and I think honestly, that's one of the biggest things, one of the biggest challenges we have. We have a very large practice. So if you're a small practice and you have a few physicians and you can kind of just get around the table and say, yeah, let's try this, great. It doesn't work that way when you have 11 strong-headed providers, and so the change process is a lot slower and a lot more cumbersome. But initially, that's a time frame, and that's, you know, those are the details that we worked on before we even tried to dive into really looking at our processes, is really getting to understand who we're working with, who are the extroverts, who are the introverts, how to deal with each of those personality types and make sure they can be productive in what we're doing, and then moving forward.
And Holly, you know, as you describe your next steps, it sounds like there's not a point in which you say, yay, we're done, we are a patient-centered medical home, let's sit
oh my
back.
God.
So maybe you could describe a little bit of, you know, as we describe it with practices here in Colorado, it's really about a journey, and maybe you can talk a little bit about that as well.
Yeah, absolutely. I feel like of that whole wheel of all the things that we need to accomplish, we've scratched the surface maybe on some of them, you know. And but I think the idea of it being a journey, and the idea that you've now gone from, well, this is the way we do things, and maybe we'll try this, and if it doesn't work, we'll just scrap it and go back to the old way. You know, that idea is gone. Now, when we look at something, we have processes for how to look at something. When we change something, we make sure we get feedback on it, and when it's not working, we have a well-defined process on how to move forward. And it's just a matter of always being in that change process and that improvement process and trying to get everybody involved, that the decisions don't just come from top down, that the decisions, everybody can have a good idea. And when everybody feels like they're empowered and they're helping make the decisions on how the practice functionings go, then clearly they're hopefully a little bit more invested. So it is definitely a journey. I feel like there's way more things that we have to do.
Great, thank you for that. So I think there was an incredibly practical question. How do you pay for these changes? And I know you're part of a health plan funded patient-centered medical home project, so maybe you could just briefly touch on the payment methodology that helps support your efforts.
Yeah, and I'm, just in terms of if somebody's thinking about doing this, when you looked back at the national demonstration project that the American Academy of Family Physicians did, that was transforming practices into the medical homes without having any special payment model in the existing model, and most of them found that they were better, they were higher functioning and more reimbursed by doing some of these initiatives. But in our case, the payment methodology is we still build fee-for-service as we saw the patients that are in this model, but alongside of that, the payment methodology for what we would have been paid for the care we provided if we didn't bill fee-for-service, just based on how sick those patients were and what the plan thought it would cost them to care for us. It was almost identical. It was amazing the first year. Of the 3 practices, they got it so spot on, so that in the future, if we're not studying it anymore and we don't have to do the fee-for-service billing, then that'll clearly free up some resources. But, so that's the incentive, is that, if the patient needs an email or a phone call or something that doesn't necessarily involve a way to bill, then we can do it, because how much of that do we do in our day that we can't bill for, and that's really what the patient needs. But how do you pay for it? I know it's definitely one of those things that we always have to consider, because right now our 2-year pilot is ending, so we don't get as much funding as we did before. We're hoping that the things we've changed, such as allowing more time for our patient visits and things like that, are still going to be feasible as we get less of that support. But hopefully some of the processes that we've set up, we're hoping that it's still going to go that way. I think making sure that what you decide to work on is financially feasible. I mean, a lot of this stuff you don't get paid for. You don't get paid for going out and meeting with specialists. In our model, we are incented to do it, because if we meet with the specialists and we encourage them to prescribe generic and not order less tests, then our scores are going to look better for efficiency. And that's not going to be the case in all models, but I suspect as we move forward with accountable care organizations and the idea that there's only so much in the bank that needs to be distributed, then those ideas are going to be much more well received, hopefully. So I don't know if that answers the question. Hopefully. You did a very nice job. I think it speaks to the fact that in order to achieve the value that patient-centered medical homes bring, we need to change the way we are paying for healthcare services. So that was very articulate. I think we'll close out our session here. We just have a couple more minutes. But Holly, if you could just briefly talk about the next steps in your organization's journey around meaningful use, and maybe just briefly touch on how you feel this links with accountable care organizations. So yeah, meaningful use, we, at least in our practice, because we're part of the community care physicians, which is the multi-specialty group, we've led a lot of the exact mechanisms in terms of how we're going to deal with this first year and the requirements. We're letting the overreaching organization and their IT department help define better for us exactly what we need to change, because they want to have it as uniform as possible across everybody that's using the same EMR, which makes a lot of sense. So we're relying on them quite a bit. We certainly are working to understand what needs to happen, but in terms of the exact details about how to make your electronic system, work for meaningful use, we're definitely relying on them somewhat. When it comes to accountable care organizations, it's just the whole idea of there's only so much out there in terms of the healthcare dollar, and if we can be the promoters of using it efficiently and preventing the unnecessary things, the things that are such the waste, like the very expensive drugs when there's a generic alternative, and like the bounce back for something silly like a formulary change that allows the patient to be on 2 medications, and by doing some of these efforts, I think that's where it all fits in, and that's where the processes around those organizations are going to have to be figured out and defined. And if we're already working on some of those initiatives to eliminate the waste, then I'm hoping we'll be ahead of the game.
That's wonderful. I think the questions that came in the chat room were incredibly inspiring in terms of the efforts that are going on across the country. We had health plans, hospital systems, individual primary care practices, organizations who work at a state level who are all supporting the efforts of moving forward in in patient-centered medical home. And as I see the question, it brings up, the work that we still have to do around integrating behavioral health, looking at nutrition services, tapping into other resources within our healthcare teams and our community. Holly, this has been an incredible presentation. I thank you so much for your time and energy. For folks on the call, Holly is a practicing physician, so she had to take time out of seeing patients in order to do the call for us, so we certainly appreciate her time. Want to let everyone know that Patient-Centered Primary Care Collaborative will be having a stakeholders work group on March 30th in Washington, D.C. I sent through the chat the website for Patient-Centered Primary Care Collaborative. That is www.pcpcc.net. We encourage all of you to consider coming to the stakeholders meeting. It is always an incredibly engaging session, a day-long session, rapid fire, where you can join with others who are moving forward in, as Holly puts it, a healthcare delivery system that is high performing and that is eliminating the waste that we know currently exists. With that, the presentation will be available on the PCPCC website. And Holly, again, thank you so much for honoring us with your time, your energy, your enthusiasm, and the work that you're doing every day.
Thank you for having me.
Great. Well, with that, we will close out our webinar. Thanks to all of you for joining.